Now we're going to dive into neuro-ophthalmology here. And the first lecture will be about idiopathic intracranial hypertension, IIH, otherwise known as pseudotumor cerebri. And then we're going to get really cerebral for the second one, which is going to be all about brain syndromes that cause some very higher order visual syndromes, which all of you will see if you look for them. Anyone here have a neuro-ophthalmologist at their institution? Anyone here? No. Yeah, okay, yeah. Okay, so that means that you're seeing neuro-ophthalmology, right? Because who's going to see them? And so it's even more important that you have a basic understanding of some of the major things that can happen in neuro-ophthalmology. So again, we're going to start with this lecture, which is about the mimickers of IIH. A mimicker, is something that looks like IIH but isn't. And my intention is that you will learn to recognize these zebras among the horses. But then we'll talk about the horse as well. We'll talk about IIH as well. Okay. I don't have any relevant financial conflicts. If I did, I would have become a hedge fund guy. But I will be discussing one off-label treatment for IIH, which is venous stenting, putting a stent in the transverse sinus for the disease as a treatment. So let's back up a little bit and talk about this condition. Okay, idiopathic intracranial hypertension. Everyone knows that you can get hypertension in the head, high pressure, from a tumor, right? You have a mass lesion. Or meningitis, or a venous sinus thrombosis, which blocks venous flow, and then the spinal fluid can't drain into the veins. Pressure goes up, and what happens to the optic nerves? Yeah, papilledema, right? They get swollen, and then you can have vision loss. But this is a disease, usually in young women of childbearing age, who have had some weight gain or are obese, where there's no tumor, there's no meningitis, there's no venous clot, yet they have papilledema and they have high pressure. And the MRI does not show really anything. Doesn't show hydrocephalus. The ventricles in this disease are normal or even small. It's really increasing, this disease, in the United States. Why? Because obesity is increasing. Why? Because of McDonald's and other fast foods and, lack of exercise sometimes, but also just sometimes genetics and really some young people just develop this disease, even without weight gain. How do you prove the disease is there? You get a lumbar puncture. Anyone here ever perform a lumbar puncture back as a student or anything? Yeah, it's a lot of fun. I love doing lumbar punctures. And it will show you normal contents. There will not be elevated white count. A normal white count is 5 white cells, okay, per millimeter. You shouldn't have more than that in the spinal fluid. If you do, you're worried about infection. But this should be normal, except that the pressure should be high, right? It should be elevated. What's a normal pressure in the spinal fluid? Anyone know? What's that? Yeah, right, exactly. So 20 if you're using millimeters of mercury. If you're using centimeters of water, which is what we use, really it's about up to 23. Once you get to 24, you're high. And how do we treat this disease? How do you treat it when you see it? Good, send them to a neurologist. I like that. Or let's say your neurologist was on vacation. They were really suffering, or they're in the hospital. You could put them on acetazolamide, right? Acetazolamide lowers the CSF production and also increases fluid outflow in the body and will lower the ICP, lower the intracranial pressure. Or if that's not available or they don't tolerate it, topiramate is actually very good. Topamax, right, which is used for seizures, but also has the same molecule on it as acetazolamide and will lower pressure. And then, you counsel the patient about losing weight and dieting and exercise, and that will slowly help them. So that helps 85% of these patients, these medicines. But sometimes they don't work and you have to move to surgery. What are some surgeries you could do? If they're suffering, they have vision loss, and the medicines don't work. Say it louder. A valve, right, or shunt. We call it shunt valve. That's great. You can put a shunt. Yeah, ventricular peritoneal shunt or lumbo-peritoneal shunt. Excellent. You were going to say? Yeah. Exactly. An optic nerve sheath fenestration, same thing. And that's really good if they have bad papilledema. Not as good for headaches. Anyone ever perform that, an optic nerve sheath fenestration? I know I haven't. As a neuro-ophthalmologist, I'll send them to Gary Lelly, and he'll do them for me when we really need it. The name of the disease is funny. At first, we called it pseudotumor cerebri, But then my patients would be, oh my God, I have a pseudotumor. They get very scared. What's a pseudotumor? I say, no. Pseudo means you don't have a tumor. It looks like a tumor. Oh, okay. Whew. But it was, I didn't like using that. So then we moved to benign intracranial hypertension because there's no cancer, there's no tumor there, which is a great name. You could call it that, but some ophthalmologists, they heard benign and they said, oh, it's benign. We don't need to worry about this. And patients were going blind. So then we decided, let's call it something else. Let's call it what it is. Idiopathic intracranial hypertension. Idiopathic means the doctors are idiots. They don't know what causes it. And we still don't know, but that's okay. So it's a tough thing, and now I've got to say it really slowly, idiopathic I just call it IIH, and the patients are relatively happy. This is the demographics just showing the increase in obesity rates in the United States, going along with the increase of IIH. Okay. Hold on, let's try this. There we go. Okay, good. The presentation, of course, is going to be headaches, worse in the morning, and worse lying down because they're pressure headaches, usually. Horizontal diplopia, right? Because they get abducens palsies. The abducens nerve comes out of the pons and then travels up the clivus bone, right? You ever know the clivus bone in front of the brainstem? And then it enters, what sinus does it enter? Yeah, the cavernous sinus. It goes through a canal called Dorello's Canal and then enters the cavernous sinus. And it's attached up at the sinus and it's attached at the pons. So when the brain sags with high pressure, you pull the abducens nerve and people get, abducens palsies, esotropia. Only the people in the front row could see me having my abducens palsy, but I got very good at it. So you look for that. Neck pain, back pain too are underreported, but they happen. And here's my favorite symptom of all, pulsatile tinnitus. They hear this in one or both ears. Anyone ever have that symptom? Yeah, I've had it. It's bad. You can't think about anything when you have pulsatile tinnitus. And so that's actually from, anyone know why they get that? Why does high pressure cause pulsatile tinnitus? Well, it's because that transverse sinus, the vein, the large vein here, is compressed by the high pressure. And when it is, the blood flow through it is very narrowed and it makes a noise and you hear it in your ear. So we'll talk about it later, but one of my areas of research is studying putting in a stent in that narrowed area. And we find as soon as we do that, the tinnitus goes away. Boom, it's just gone. So interesting. Okay, and of course, our favorite sign in this disease is papilledema. And papilledema, usually, how do patients say they have papilledema? They say, Doc, I've got something floating over here where I can't see through it, right? And what is that thing? Yeah, it's an enlarged blind spot. And they'll have one here and they'll have one there. That's early on, right? But then later they'll get visual field defects, especially inferiorly and nasally. They'll get like an infranasal depression, similar to glaucoma, almost like an infranasal step, and then eventually peripheral constriction, and then eventually central loss. So here we can see some classic visual field loss, an enlarged blind spot in the right eye, inferior arcuate. Here we've got the infranasal depression, but this eye was really bad. You can even see some central vision loss. So they had a drop in acuity. So they were farther along in their papilledema. And then I thought, hey, it's a good excuse to go through the 5 Frisson grades. Everyone know the 5 Frisson grades? It's nice to be able to put that down so when you're writing about papilledema, you can communicate it to everybody else, right? So grade 0, nothing. Grade 1, there's a C-shaped halo of thickening here, but spares the temporal side. In grade 2, the thickening is all around the whole disc. Grade 3, you start to lose your blood vessels at the border of the disc. You have vessel obstruction at the borders. But by grade 4, you are losing blood vessels on the disc. Not all of them, but some of them, like this one. There's also cotton wool spots here, which are infarctions of the retinal nerve fiber layer. And then grade 5, no blood vessels at all on the disc. When you see grade 5 papilledema, you should get tachycardic and a little bit sweaty, because these patients are at risk for losing a lot of vision very quickly. When I see that, I think about a shunt right away, okay, especially if it's new. Okay, good. Let's keep going. And you know what's interesting with papilledema, visual acuity, color vision, are they very much affected? No, they're spared at the beginning. But if you ignore papilledema, they can get involved, and then the patient can be blind. So, but at the beginning, it's like glaucoma, field loss without acuity loss. Yes, sir?
I had one patient that she mostly complained about polynuria.
Polyanopsia?
She said like she's watching you and then she turns around and she's watching you.
Yeah, sure, palinopsia. We're going to talk about that in the next lecture, if we get to it. But that's very interesting. That implies somehow that the occipital cortex had edema or something, because the optic nerves wouldn't be the localization of that symptom, palinopsia. It's usually occipital cortex. That's great, though. Thank you. I love when you have questions, because I get to drink some coffee. That's wonderful. Get that energy. All right, so let's move on. There are criteria, the modified Dandy criteria. Dandy described this disease, Walter Dandy, in 1937 in a landmark article. But in 1985, J. Lawton Smith wrote an article in which he said, let's get some sort of modern criteria. And the criteria are they make a lot of sense, right? Signs and symptoms of ICP, but no tumor. But you can have some cranial neuropathies. We already said you can have cranial nerve 6, but actually you can have cranial nerve 7. Facial palsies can occur from the high pressure, and even hearing loss, cranial nerve 8, okay? And you're supposed to have a normal MRI. Everybody, is this a normal MRI? Would this be IIH? I know you don't look at MRIs all day long, right? But this is a brain, all right? This is a coronal view of the brain. These are the veins, like here and here. But what is abnormal about this brain? Okay, the ventricles are a little small. True. They're certainly not enlarged, but they could be normal. But what is even more abnormal? That's right. Look at this. The dura, the meninges, is lighting up with the contrast, even into the sulcus. This is what we call leptomeningeal disease. This patient had meningitis, and you can see it on MRI, filling up the sulci in the brain and around the brain. So if you see that, it ain't IIH. That's meningitis. You got a lumbar puncture, get them on vancomycin and zosyn, and treat their meningitis, or see if they have some other cause, like syphilis. Okay, so normal neuroimaging. And yet, when I tell you that they should have normal imaging, I'm not really telling you the truth. Because there are signs when you get your MRI of IIH. Here they are. Number 1, increased CSF space around the nerve. This is an orbital MRI. I encourage you always as ophthalmologists, make sure it's an orbital MRI. None of this brain MRI. You're not going to see the orbits as well. Fat saturated if possible. Get rid of the fat signal for your T1 post. But this is a T2. In a T2 MRI, the spinal fluid is bright, and you can see the optic nerve so well. And often with high pressure, the nerve is kinked, and the posterior globe bows forward like this because of the pressure is pushing it forward. So you got increased CSF and bowing forward and a kinked nerve. And this is called an empty cella. What's supposed to live right here, everybody? Yeah, pituitary gland. I don't see a pituitary gland because the pressure is squashing it down. That's called an empty cella. Okay, so we look for that. And there's more. Here on T1 post-orbital fat sat MRI, you can see enhancement of the nerve. often in papilledema. And on T2, you can see an enlarged area called Meckel's cave, just medial to the temporal lobe, because the CSF is stored there and it's kind of enlarging. And finally, you can sometimes see a Chiari malformation where the tonsils of the cerebellum are pushing down because of the high pressure. And finally, my favorite sign, venous sinus stenosis. This is called the superior sagittal sinus. It's draining the head, and then it turns to each side, forming the transverse sinus. And then it forms this like S-shaped vein called the sigmoid sinus. And at the junction of the transverse sinus and the sigmoid is where there's this narrowing in this disease, often bilateral. Okay, so look for that as well. Any questions so far? That was an overview of IIH. Okay, has anyone here seen IIH in a patient? You've seen it? Yeah, you will see it. And these patients really need your help. They need you, the ophthalmologist, help, because I'll tell you what, your neurologists, they cannot follow these patients without you, because they don't know what's going on in the back of the eye. They might know if there are headaches or whatever. You are the key to protecting these patients from blindness. Now we're going to jump in and talk about some interesting cases that mimic IIH. And I call the first one, case 1, devil in the details. Okay? This was an 8-year-old boy, and we can probably put the lights back on. Otherwise, I might start having a nap. I need some lights, yeah. Okay. A little bit lighter. Okay, good. So this is an 8-year-old boy who presented with daily headaches back in 2018. They would start upon awakening, sounds like high pressure, and ibuprofen would treat them. He gets a little antibiotics, CT, head CT is done, no sinusitis. MRI is normal. Okay, everyone's happy, MRI is normal. But 1 month later, he develops acute blurry vision in his right eye that resolves after seconds. Now, I didn't talk about this symptom, I forgot to, but here is an interesting symptom. He sits up, he stands up, boom, goes blind for 1 second, and then he gets his vision back. What's that called? It could be vasospasm, that's a good point. But in the setting of high pressure, we call it transient visual obscurations, right? Because the disc, the optic nerve, is so swollen that when you stand up, the blood flow can't perfuse it because your blood pressure drops when you stand up for a second. You know, you feel dizzy for a moment, right? So that's transient visual obscuration, TVOs. It's part of papilledema. And this would happen in both eyes for him. And so he's found to have papilledema, is sent to the emergency room, and the ER doc calls me up. Hey, Dr. Dinkin, I got a pediatric IIH patient for you. I say, great, I love pediatric IIH. I put my hat on, I run out the door, I run over to the ER, and then I see there's grade 1 papilledema and grade 2 papilledema. I perform an OCT on this patient. Retinal nerve fiber layers, 200 in the right eye, 247 in the left. This certainly looks like IIH because his MRI was normal a month ago. And, you know, his MRI shows some signs of IIH. The orbits show the papilledema, but they're read as normal by the neuroradiologist. And a lumbar puncture is performed. Opening pressure is 28. Is that high? Yes, it is high. WBC 7, RBCs 18, protein 66. No oligoclonal bands, which is a test for multiple sclerosis. And everyone says IIH. Is that IIH? No. Why not?
It's not female, it's not obese.
He's not obese.
He's not using too many thousands.
All correct. Number one, he's a child. Do children get IIH? They actually can. Pediatric IIH. And in children, males equals females. And in children, you don't need to be obese at all. Most of them are thin or not obese anyway. So it's still good. These are all good points you make, but in an 8-year-old, still could be pediatric IIH. But, oh, I didn't do that right. Hold on, let's try that again. WBC is 7. That's a little high, but the neurologist said, it's close to 5. It's still IIH. And I said, okay, IIH. But then I sat down, and I really sat with the MRI. You should look at every MRI you get, everybody, because as the ophthalmologist, you are more equipped to study the orbits than even the radiologist, I think. So you should look at it, because I looked at it. Now, first of all, I didn't tell you this yet, but this kid's visual acuity was 20, I think 40 in one eye and counting fingers in the other eye. Counting fingers with this optic nerve, grade 2, I'm thinking to myself, that does not compute, right? Papilledema can cause counting fingers when you have grade 4, grade 5, really bad optic nerves. This looks like it's not that bad. So I'm thinking he should not have that bad vision. Something else is going on. So I looked carefully at the MRI, and I bought a sandwich, and I had the sandwich while I looked at the MRI. If you really want to look at an MRI well, you should eat a meal and look at the MRI. Okay? It's going to take more time. And I see he's got papilledema. He's got the increased CSF space, a little bit of enhancement at the discs, which they called, empty cella, venous stenosis. Anyone see anything else?
There is like a malformation on the vascular side on the right side.
And this one?
No, on the
Here?
down,
Here?
down to the
Here. Oh, this?
no to there.
Oh, yeah. You're right. That is a very interesting kind of thing. These are just cortical veins that are coming out, but they look like a malformation because of the stenosis. But it's a good pickup. And sometimes you can see malformations there, and you can see a diverticula and things like that. Really good pickup. But I started looking at this one, and I'm looking, and this is a brain MRI, so there's no fat saturation. Remember how I said I love fat saturation, where you get rid of the fat signal? But if you, in your mind, get rid of this white signal, what does everybody think of the color of the optic nerves? They're bright. Yeah, they're enhancing. This is bright. It should be dark, because it should be dark like here, but it's bright. It's just hard to see because it's not fat sat. Yeah, I'm thinking, wait a minute. Yeah, he could have enhancement of his disc with papilledema, but papilledema doesn't cause enhancement of the whole nerve. Something is wrong. What does he have? You said inflammation. What do we call inflammation? He's got optic neuritis. But can optic neuritis cause disc edema? Yeah. What percentage of optic neuritis has disc edema? Anyone know? Yeah, a third. Wonderful. 33%, especially in MS. So he could have it. So, wow. He's got, and look at this. The radiologist called this a venous anomaly. There's another venous anomaly. Okay, but we'll get back to that. I looked at that and said, I'm not so sure. So he practically fulfills the dandy criteria, but not really, because A, his MRI isn't actually negative, and B, his WBCs are high. So then, and here's the counting fingers. So we then look at the DWI, and we see some diffusion-weighted imaging, positivity of the optic nerve. You only get that when there's ischemia to the optic nerve. So something's going on here. And we actually get another MRI, this time an orbital MRI. I love orbital MRIs. I just love them. And I always try to get them. Here you can see the enhancement of the nerve on the right side more than the left, really enhancing, going all the way down. You can see it on coronals, okay? And you can actually even see the trigeminal nerves are enhancing a little bit. So the MRI orbits really showed everybody this was optic neuritis, bilateral, okay? And then we got some blood tests. And anyone ever see MOG? Okay, so anyone ever see aquaporin 4? Right? What do we call it when their aquaporin 4 antibody is high? What disease is that? De Vic, right? Described right here in Europe, in France, by De Vic in like 1892. De Vic's disease, or neuromyelitis optica, is like a type of multiple sclerosis, except it mostly affects optic nerves and spinal cord, hence neuromyelitis optica. And with NMO, neuromyelitis optica, the first antibody they found was against aquaporin 4, which is a water channel. In what cells? Anyone know? What's that? And what cell has that aquaporin 4 channel that the antibody is attacking in NMO? It's actually the astrocyte. The astrocyte, which is forming the blood-brain barrier. And so you get all this inflammation, and the astrocytes die, and then the neurons die. But a few years ago, we started seeing, hey, there are a lot of people who look like neuromyelitis optica, but when we check for the aquaporin 4, antibody, it's not there. Yet they look like they have it. And then we finally found out, just in about 2015, that some of those patients had a different antibody against myelin, oligodendrocyte, glycoprotein, MOG. What cell is that protein on? The myelin oligodendrocyte glycoprotein. Yeah, the oligodendrocyte. Right, very good. Just checking if you're listening. Okay, so, and it's on the oligodendrocyte. What does the oligodendrocyte do? What does that cell do? Yeah, it forms the myelin sheath all day long. So if you kill the oligodendrocyte, what do you get? Demyelination. Exactly. Optic neuritis in this case, and transverse myelitis. And his titer was really high. So I want everyone in this room now to forever know about MOG-associated disease, MOGAD, okay, MOG-associated disease, and to know that it can cause optic neuritis. And one of the things about MOG that's different from aquaporin 4 is actually, although it's often severe vision loss, like counting fingers, when you give them a certain treatment, it will almost always make them better if you get to them fast enough. Unlike aquaporin 4, which often does not get better. So you have to treat both. You have to treat them. In the optic neuritis treatment trial, what was the effect of IV steroids on the visual outcome a year later? Anyone know? Nothing. They got better faster, right? But the conclusions of the optic neuritis treatment trial were you don't actually have to give them steroids because 95% are going to get back to 20/40 or better. You can just give it to them and they'll get better faster. But if you have aquaporin 4 or you have MOG, you have to treat them. Their outcome will depend on it. Okay? And my attitude is anyone who comes to me with optic neuritis, I treat them. Intravenous steroids. Because I don't know yet. How long does it take for these blood tests to come back? 2 weeks. When it comes back, what am I going to go back in time and treat them? You got to treat them now. So I treat, and then worst comes to worst, I made them better faster. But if they have aquaporin 4 or MOG, I know I did the right thing and they needed it. So I usually treat optic neuritis. So look for MOG. When it's MOG, they're more likely to have bilateral, like him, just like aquaporin 4, and they are more likely to have disc edema. Remember how we said 30% of optic neuritis has disc edema? What percentage of MOG has disc edema? It's like 60%. So, you know, if you see disc edema with optic neuritis, check MOG. And I bet if you look into it, in your institution, you could probably send MOG. Who can send aquaporin 4 in their institution? Do you know? Yeah, I mean, if you look for it, probably, and work with your neurologists, okay, you can send MOG too. All right, great. So, with IV methylprednisolone, the vision improved to 20/20 in both eyes. Can you imagine? And oh, by the way, the other point of this story is that very rarely MOG, because of the inflammation or what have you, can mimic IIH because you can get high pressure. Because remember, he didn't just have optic neuritis. He had signs of high ICP on his MRI, and his pressure was 28, which is high. So he had a kind of IIH syndrome from his MOG. Okay, sorry, I didn't make that point yet. And by the way, that little DVA, the venous anomaly that was enhancing it, disappeared with steroids. And I've been watching him now for many years, and he's been okay. Many children just get one attack of MOG. And these are some other articles that show MOG where it mimics IIH, where you get high pressure. A few cases in the literature. So ours was like, you know, rare but not unheard of. Okay, take-home points. Beware inflammation. When you see IIH, think to yourself, is it really IIH? Or is this inflammatory? Okay, and remember, MRI findings of high intracranial pressure are not only found in IIH, including venous stenosis, emptycella. Anytime there's high pressure, whether idiopathic or not, you can see these signs. And optic nerve enhancement, this is an important point, can be seen on brain MRI without fat saturation, but it's difficult. Our radiologist missed it. A good radiologist too, but they missed it. And read your own MRIs. You may find things your radiologist missed, and you will save your patient. Because can you imagine if we just treated them with acetazolamide and not the steroids? This poor kid would still have counting fingers in his right eye because you need steroids in MOG. And so we wouldn't have sent them on. So you really have to look carefully. Okay, good. Let's go to case 2. I call this vascular enhancement, question mark. He's a 12-year-old boy, developed nausea, vomiting. Can that be a sign of high pressure? Nausea, yeah, it can, nausea, vomiting. Then he gets diplopia and blurry vision. He's found to have bilateral Dussen's palsies and papilledema. Okay, and you can see the papilledema. What grade is this, everybody? Yeah, it's grade 4, almost 5, but we still see some veins on there. And this is a little bit less, but pretty bad papilledema. MRI is normal, lumbar puncture, elevated pressure of 55. This isn't 28, this is 55, really high. And the contents are normal for white cells, everything's normal here. We do an infectious disease workup, normal, and he's diagnosed with pediatric IIH. He is a thin boy, but the modified Dandy criteria are fulfilled. And they send him to me after starting acetazolamide. You can see high retinal nerve fiber layer too, 310 and 353. What about the visual fields? Anyone want to read these visual fields? Behind the chiasm? Yes. Good. Good, yeah. I mean,
We should expect something like large blind spot, but you don't have here.
yeah.
Or something behind.
Wonderful. I agree. Tell me your name again. Amra. I agree with you, Amra. I mean, it's not that typical for papilledema because here you've got central vision loss. And here you do have nasal vision loss, which is common with papilledema, but it's weirdly respecting the vertical meridian. But, you know, if it were retrochiasmal, then you'd have a homonymous loss on the other side, which sort of not really. And if it were chiasmal, it would be on the temporal side. So I wasn't sure what to do with it, but he's a kid. And children, they're not always that accurate on visual fields. But either way, I knew that he had a lot of vision loss from it. This was a serious case. And we get the MRI and we see all these signs. Increased CSF, empty cella, venous stenosis. You're getting the gist. We're seeing this a lot. And anything else? Well, I don't know how well everybody can see it. But does everybody see, what part of the brain is this? Cerebellum. You guys are good. You're good. You could be a neuro-ophthalmologist. You see the cerebellum. That's good. What's abnormal about that cerebellum? Yeah, there's enhancement right here on the anterior side. So I look at the radiology, and I call the radiologist and say, hey, there's enhancement. You missed it. And the radiologist say, okay. And they point it out, and they say there's a little vascular enhancement in the cerebellum. Differential includes dysplasia, like from birth, or maybe it's just due to the elevated ICP and vascular congestion. It's not likely that it's infection or inflammation or neoplasm. What do you think? Is it not likely? Bless you. I wouldn't be giving this talk if it was just vascular enhancement. So, yeah, it could be inflammation like our last case. Well, I saw it and I was worried. So I said, let's go send some cytology on the CSF. Make sure this young boy doesn't have cancer. And in fact, there were a few atypical hematopoietic progenitor cells in the CSF. In other words, cells that are like pre-white cells or red cells. So I get oncology. I'm worried about this kid. Oncology says, nah, he doesn't have leukemia, doesn't have lymphoma. I mean, he looks fine otherwise. He had 0 white cells in the spinal fluid. He has no night sweats. It's IIH. I say, phew, and I go home. But you know what? Despite his acetazolamide, his disc edema worsens. And I get really worried. I send cytology 3 times. I'm so worried about this kid. Lumbar puncture 3 times. Because you have to do that to rule out cancer. Every time the sensitivity is only 30%. So I do it 3 times. Still nothing. And I don't know. And actually the opening pressure is normal because we had put in a shunt. We were so worried. A ventriculoperitoneal shunt. So we were treating this kid. And we even did an optic nerve sheath fenestration. He's still losing vision. So I call up the neurosurgeons. I say, you guys, we got to get a biopsy of that enhancing area. I'm so worried. So we do it, and a cerebellar biopsy was performed. Okay, this is the cerebellum, not pathology you look at all day long. These are Purkinje cells, small granular cells, but here, where they shouldn't be, we have these large atypical cells infiltrating the cerebellar cortex. So he had, anyone know what tumor in children? You got it. This is wow, very good. This is a medulloblastoma. And unfortunately, a malignancy, which is high grade. And most of the time, when you have medulloblastoma, you see a tumor in the cerebellum, a round tumor. Yeah, but here you're just seeing leptomeningeal disease. You're seeing cells that are coating the cerebellum and in the cerebellum a little bit, but it's not forming a mass. And it's a leptomeningeal kind of infiltrating the spinal fluid, presenting like IIH. So, what's the moral of the story? Medulloblastoma can present as an isolated lepto disease. But more importantly for you is that the MRI findings in leptomeningeal disease, when you have cancer of the spinal fluid, which is what lepto means, can be very subtle. And you have to have a clinical suspicion for it. In this case, why was he losing vision even though his pressure was normal? Anyone know? Yeah, I agree with you. I can't prove it, but I think that the medulloblastoma was infiltrating the optic nerves and causing vision loss. So we could put in a shunt, fenestration, it wasn't going to help. He needed chemotherapy and radiation, which he got, and he did better. And he's still around, thank God. This is 6 years later. Even more, 7 years later, and I see him every 6 months. And his vision improved a lot. Not perfect, but a lot. And here is a similar case in the literature. Medulloblastoma as isolated lepto. Okay, good. Any questions? Okay, case 3. I call this case trifecta. Trifecta means you got not 1, not 2, but 3 problems. So this was another young boy, 8-year-old. He gets hit in the head with a soccer ball. And he gets brought in because he's got a floater. Okay? You've probably seen this. And he goes to the retina guy or the general guy, and he's got a vitreous detachment. All right. But then he looks in the back, and he says, oh my God, there's bilateral optic nerve edema. And this guy also has IIH. He sends him to me. We get an MRI. It's normal, an MRV. It's unrevealing. This is all in the ER. An LP is performed, and the opening pressure is 27, just on the border. And he's sent to me for IIH. But I talk to him. I say, kid, you got headaches? Nope. Do you have any whooshing? Nope. Any TVOs, transit? Nothing. He has no symptoms. So I start to scratch my head. Now, children may have no symptoms in IIH, so okay, could be. And he's got, does everyone agree there's disc edema? What grade is this? Yeah, it's like 2. And he's got these kind of peripheral field loss. Does the field loss look like appropriate for this amount of papilledema? It's a lot, right? What's going on? And he's got 158. Normal RNFL is what? What's normal? Yeah, 100 in a child. Definitely no higher than 120. And usually 90. In adults, it's like 80. So this is a little high, but it's not 300. So, okay. So then I back up. And I start to pull out my 20 and I do an indirect. What does he have? Yeah, he's got RP. He's got retinitis pigmentosa. Wow, that's a trifecta. He's got a PVD from the soccer ball. He's got IIH. And he's got retinitis pigmentosa. I mean, that's a difficult discussion to have with his mom. There's a lot going on. And I say, well, maybe he actually has IIH too. But I start to think, could he really have all of these things? And then I look in the literature and I find a paper by Robert Avery, who I know pretty well, who looked at opening pressure in children and found actually that opening pressure in children, normally, when he looked at a bunch of normal kids with lumbar punctures, can be as high as 28. So I thought in this case, 27, while on the higher end of normal, could actually be normal. And that explains why he has no symptoms. But then why does he have disc edema, right? Well, I started to think that, let me go back, that his disc edema was actually from his retinitis pigmentosa. Rarely, in acute stages of RP, you can see optic disc edema. And here's a bunch of signs in it. Okay, anyone ever see that? It's because as the photoreceptor layer and the RPE is degenerating, it kind of goes up, of course, it lifts up, and it can cause some inflammation. And the retinal nerve fiber layer can become inflamed and increased in size, and around the optic nerve, that looks odd. But actually, when I looked on the OCT at his optic nerve, the optic nerve itself was not thickened. The optic nerve itself was not being pushed forward as it usually is in high ICP. So I think this looked like disc edema, but was really just a thickening of the RNFL because of retinitis pigmentosa. So take-home point, retinitis pigmentosa can rarely produce disc edema, and other retinal conditions can rarely produce disc edema. And always look at your visual fields carefully and say, does that match the optic nerve? If not, look for something else, which is what we did here. He had RP. And I follow him. He's doing great. This is about 10 years ago.
Did he only have floaters? His vision was okay?
Yeah, he was 20/20. He had a floater from the posterior vitreous detachment, and he had field loss from the RP. But one of the evidence to me that this was RP field loss and not disc edema field loss was that he didn't notice it. If he had acutely gotten it because he had developed IIH the week before or something, he would have really noticed it. But it happened slowly over time from RP. Okay, let's look at case 4, winking at the iPad. This was a 6-year-old, thin girl with a history of a disease called hypophosphatemic rickets. Anyone know what rickets is? What is it? Yeah, you get low vitamin D, rickets, not rickettsia, rickets. No vitamin D, they're not drinking enough milk, and so their bones don't develop well, and they walk bow-legged, right? Rickets, okay? Rakits. This is why I love this week, because I'm learning from you how to say it, and you're like, oh, that's great. Rackets, okay, great. She had hypophosphatemic rickets. Why? Because genetically, she doesn't absorb phosphate. And if you don't absorb phosphate, you can't make bone, because bone is made of calcium phosphate, okay? So she's not making bone. So what did they do? They've been giving her phosphate infusions since she was a little girl. She's still a little girl, 6 years old. So, okay, but that's just in the background. One day, mom sees that she's on the iPad. This is great. She's on the iPad playing, and she's going like this. Why is she doing that? Yeah, she's got diplopia avoidance. So they bring her in. Sure enough, she's got an abducens palsy, and she's got papilledema, little papilledema there, 451 microns, 345. And she's got some field loss, large blind spot, infranasal depressions. We get an MRI. Wow, is that big CSF space, everybody? There's a lot. You could drive a truck through the CSF here. And empty cella. You haven't even seen a normal cella yet today. No, I'll never show it to you. And venous narrowing. So she's got everything. And the radiologist says, IIH. And the ophthalmologist says IIH. Well, okay. So, but before I do the spinal tap, I review the MRI with Linda Heyer, my radiologist, who's wonderful, and we see a few things. Here we have one of the signs of high ICP. What's going on here, everybody? Yeah, her tonsils are herniating. Not the tonsils in the throat, but the cerebellar tonsils. And that's called inferior tonsillar herniation, and it's not good. But she doesn't have headaches. It's probably been going on for a while. But if you look carefully, you can see here's the medulla, and here are the tonsils that should be there around the medulla. So my radiologist says, if you perform a lumbar puncture, she could die. She'll herniate. So don't do a lumbar puncture. So I still don't know what her pressure was, but I know it was high. So we never did a lumbar puncture. And then my radiologist says, you know, it's weird. Her bones are kind of scallopy. They developed weirdly here. Why are her bones scalloped? Yeah, rackets. Right? So, you know, she's got this, she's got weird bone formation. And then I start to think, maybe it's all connected. So I get one other test that gives me my answer. And, well, first of all, what's weird about this MRI? Anyone see something abnormal in this MRI? Yeah. What's weird about it is it's a very long brain. Yeah, it's compressed, right? She's very good. It's a very narrow brain. This should be more of like an oval. This is like, okay? And so what does she have? Wonderful. She has craniosynostosis. And it's called scaphocephaly is a type of it. Okay? And so we go on and we get this, a 3D CT of the head. What's missing, guys? She doesn't have the sutures. There's no superior sagittal suture. So she has craniosynostosis due to X-linked hypophosphatemia, which has been described. But normally, how old are kids when you discover that they have craniosynostosis? Craniosynostosis, for those who don't know, means that the sutures fuse. They never really form sutures. So it's like one big bone. So the brain is enlarging, but the skull is not, at least in one direction. And it's bad because why? The child can have a deformed head and they can have high ICP. But how old are they usually when you find this? Babies. She's, 6 years old. Could they have missed craniosynostosis for 6 years? It is secondary. And in secondary, it may develop a little bit later, and it can be missed. Here's this wonderful, lovely young lady. Her head looks okay, actually, because it's scaphocephaly. If you look from the side, you might see she's got a kind of long head, but when you look from the front, she's adorable. Yeah. And so her mom didn't notice it. Frankly, I didn't notice it when I met her. I just saw her winking. And so what did we do? We sent her for cranial vault reconstruction with the neurosurgeon. And 1 month later, normal optic nerves, normal visual fields, and she's great. And here's another case of papilledema in the setting of X-linked hypophosphatemic rickets with craniosynostosis. So what are the take-home points on this one? Here's craniosynostosis. You should know it because they often present with papilledema. Anyone here see children or babies? Well, one of you. Okay. Well, anyway, if you're ever called to see kids, they can have this. And these are the kinds, I won't go through them, but these are the kinds, they're in your slides, of craniosynostosis, depending on which suture is fused. And remember, it can be related to genetic defects. Sometimes it's not recognized. And the most important thing is it can be missed on MRI. You need that 3D CAT scan. And when you see a child with papilledema, think about it. Because I actually, after that case, I then collected 4 more cases of craniosynostosis, not in babies, but in 5, 6, 7-year-olds causing what was called IIH, misdiagnosed as IIH, but was craniosynostosis in all cases. And some of them did very well. Then I went back and I looked at all of our children with IIH, 109 with papilledema. Of these, 78 had no known cause and were thought to be papilledema from IIH, okay? These were pseudopapilledema like drusen. And then I looked back and said, well, what did they have? And what I found was of these 78 kids who were sent to me for IIH, 51% had IIH. Another 5% had IIH but no papilledema. But then all these others had other things, malignancy, 4, craniosynostosis, 4, benign tumors that were missed, 3, hydrocephalus, 2, RP, actually 2, and inflammatory infectious, 8. So the take-home point, everybody, is there can be other things that cause high ICP. When you have IIH in a child or an adult, really think carefully, could it be that it's not IIH? And we have one last case in this hour-long lecture, the last 10 minutes. This is my favorite case. This was an adult, 20-year-old thin man. Now here's where you have to say to yourself, wait a minute, thin man, not likely to be IIH. 90% of patients with IIH are obese or overweight or had weight gain, and 90% are female. So it'd be very unlikely. But he has migraine aura, and in 2003, he's pouring cement in Boston. Anyone ever been to Boston? Around the time, Boston had something called the Big Dig. And the Big Dig, they were digging up all of Boston, putting in like underground highways. So he was working at the Big Dig. And every time he would pour and bend, he would suddenly get the worst headache and then vomit and pass out. And his coworker, oh my God, he's passed out. and it would bring him to the ER. He'd be fine. He'd go back to work the next day. And so he had to learn to pour the asphalt like this because he wouldn't want to bend down. And then finally, an ophthalmologist sees papilledema. You see papilledema, both eyes. So something's going on.
It looks weird. It looks like everything around is like bullshit.
Well, yeah. I mean, what you're noticing, I think, is this thickening of the retinal nerve fiber layer around the optic nerve. So you can see that sometimes. These nerves, it's hard to see without looking in 3D, but they're popping out at you. So under the slit lamp, they're like little mountains. So good pickup. So we get a brain MRI, normal. We get a brain MRV, normal. We get a lumbar puncture, actually normal contents, and his opening pressure at the time is normal, 11. And then 2 months later, the papilledema resolves. But the following year, he comes back with diplopia, pulsatile tinnitus, papilledema's back. We admit him to the hospital. It's very weird. This is a guy who gets high ICP, then it goes away, then it comes back. Something's happening that's changing things. So we get a brain MRI. We see enlarged optic nerve sheaths, anterior bowing. Lumbar puncture this time is high, 25. We diagnose him with IIH, and I say, problem solved. I pat myself on the back. I order a pizza, I go to my office. I'm really having a good time. But 2 hours later, I get a call from the neurology team. Dr. Dinkin, our patient that you just performed the lumbar puncture on has developed numbness and urinary retention. What have I done with my lumbar puncture? I'm so upset. What do you think's happened? Inflammation? Is that what? Oh, wait, say again?
Inflammation of the cerebellum.
Oh, like herniation. Yeah, sorry, hernia. Could be he's herniating. But he's got numbness, I didn't say. Numbness down here, like in the groin area, and urinary retention. Yeah, something on the spine. It's like a cauda equina syndrome, or conus medullaris. And I'm thinking, I must have caused a bleed. I shouldn't have, put the needle in, and I'm so worried. So what are you going to do now? What do you want? MRI. In neuro-ophthalmology, when you ask a neuro-ophthalmologist, what do you want? They either say MRI, aspirin, steroids, or a pay increase. Those are the 4 things. And I can only get 3 of those things. You can guess which ones. Okay, so here we go. We get an MRI. I just made that joke up. All right, so here we go. And what do you see? You see something abnormal. Who can tell me what's going on with this guy? Is there a bleed? What's going on? That is the international sign for a CSF cyst. Very good. He's got a cyst. Excellent. He's got a cyst. And it's been there for a long time because it's eaten away at the bone. This guy has this weird big cyst in his lumbar spine. Okay, so we do a CT myelogram. The myelogram, we put dye in his back, in the CSF space, and it ends up in the cyst. Now we know that the cyst connects with the CSF. So what was happening when he was pouring asphalt? Yeah, either the cyst compressed the CSF space and ICP went up, or what else could have happened? Yeah, there could be what's called, go ahead, yeah? Stealing fluid. When he bends, it pushes like a pump fluid from the cyst into the CSF. Suddenly, it's like adding, a few milliliters of volume into your CSF, and you get what's called a pressure wave. In a pressure wave, the ICP goes up, and you can't perfuse your brain, and you get, boom, you pass out. So with really fast, high increases in ICP, you can get a pressure wave. And that's what we figured he have. And this is called a slit valve effect. There's a little slit between the cyst and the CSF, and it's a one-way valve. So the fluid goes in, but it doesn't come out. And he gets this. And then eventually it normalizes, and his disease would go away until he starts bending again on another big dig job, and he would get it again. So, mimicker number 5, spinal disease. And we found another paper of 5 cases of paroxysmal, which means sudden, raised ICP with spinal meningeal cysts, just like our guy. And we actually published him in the New England Journal. It was so interesting. Here's the diagram of it. And he did great. We took him to neurosurgery. They fenestrated the cyst, and he woke up It's Dr. Dinkin. For the first time in 10 years, I don't have a headache. And it was beautiful. It was beautiful. He didn't even realize he had a headache because it was so constant from the cyst constantly pushing, just like you said, on the area. So again, think about spinal disease. Bonus round. Ding, 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 ding. 47-year-old man with hypertension and ulcerative colitis presents with one long month of headaches, pulsatile tinnitus, blurry vision, and it looks like he's got papilledema. Here we get an OCT here, and we see 279, 243, papilledema. What is this here? It's got hemorrhage, and what's this? And here? Yeah, good, infarction or cotton wool spots. So he's got cotton wool spots, he's got hemorrhage, he's got the real deal. Okay, papilledema. And so what do you want? What's next? MRI. You guys are good at this. MRI normal, MRV normal, lumbar puncture, high pressure 36, WBC2. Is it IIH? Does it fulfill the criteria for IIH? Yes, it does. He's got IIH. I wanted to include one case of... No, this is not IIH. Look at the protein. 403. Is that normal? No, it's like, it should be 35. So, wow, suddenly we get the protein back and our jaws drop. Something's going on with this guy. So, since the brain looks normal, move on to the spine. When you have a spinal fluid problem, remember it's CSF, cerebrospinal fluid. Something could be going on in the spine. What's wrong with the spine? Yeah, he's got a tumor right here, and there's obstruction. That's called Freund syndrome, where the spinal fluid cannot move around a tumor, and so it can't drain in the areas of the spinal cord, because that helps drain too. Pressure goes up in the head, high pressure. That's called Freund syndrome, and this mass was biopsied. It turned out to be a primary melanotic nervous system tumor exhibiting leptomeningeal dissemination. They radiated it. His papilledema went away. He's doing great. So, case 6, last one, promise. Pain in vein. This guy has papilledema, and what happens? We check the opening pressure. It's high. They recommend a shunt, but actually, I say to him, I do something that nobody had done. I take a history. Nobody had taken a history. I say, anything going on the last month? He goes, yeah, I had a surgery, but it's not important, doc. It's not important. Where was the surgery? He goes, it was my neck. It wasn't in my head. Well, what did they do in your neck? They took a cyst, a little branchial cleft cyst out. So I look at the operative note. The surgeon took out the cyst, but they also sacrificed the internal jugular vein. Gone. Yeah, that's what I said. I'm like, oh my God. And so, in fact, he was one of those people, and this is a lot of us, where one vein was the dominant one and one is non-dominant. They sacrificed the dominant internal jugular vein. That meant that venous flow was not doing so well, was not leaving his neck or coming down to his neck. Stasis, and then he had venous sinus thrombosis. So instead of putting a shunt in this guy, what did we do? I called the surgeon. I said, you're going to have to religate his IJ. And he did. He put in a new fake IJ, and he connected it up, and he got better. So always think about the venous system, okay? Because venous occlusion can mimic IIH. This was a young lady who had venous sinus thrombosis from an infection. What grade is this, you guys? This is grade 5. So I put in a shunt, but it got infected, and then she had venous sinus thrombosis, and then we had to do optic nerve sheath fenestrations. And look at that, terrible. This is one of the worst cases. But she did well eventually. And here was another case where it looked like IIH. Does the brain look normal? Brain's okay. It's okay, brain. But if you look down a little bit, tumor. And this tumor is pushing on the IJ. Here's the IJ. Anyone know what tumor sits in your neck and pushes on the internal jugular vein, giving you tinnitus? And it's benign, but it can be really bad. And it increases ICP. This is called a paraganglioma or a glomus jugulare tumor. You may have heard of it. And it can cause high blood pressure by pushing on the carotid sinus there. So this was another case where it was in the neck. So anyway, always think about your veins. Here's papilledema, which led to atrophy from a dural arteriovenous fistula. Okay, an abnormal connection between the arteries, the middle meningeal artery, and the venous sinus. And we had to send him for repair of the dural arteriovenous fistula. So, good. What about the rest? it turns out, you guys, that normal IIH can also have something to do with the veins, like I promised I would tell you. And we now know that venous sinus stenosis can cause IIH, or at least be part of IIH. And in Walter Dandy's original paper, 1937, that we mentioned, he theorized that there may be problems with the cranial vascular bed. Here's one of our patients, IIH, real IIH, doing not so well. Look at the 404, I don't know why it's cut off, thickness, field loss, stenosis, bad papilledema. They come in, what do we treat them with? What do you treat IIH with? Acetazolamide. 4 weeks of acetazolamide, increase. They're still doing badly. She calls me up, Doc, that pill's not working. What do you do now? Shunt. I say to her, we have 3 options. Shunt, fenestration. Well, she was doing so badly that I didn't want to mess around with topiramate, but you're right, you could do it. Say shunt, CSF shunt, optic nerve sheath fenestration, or we could do this new thing of venous stent. She says, I'll take the stent because I don't want you to open up my skull. So the stent is put in through the femoral vein, and the interventional radiologist deploys a stent, and it opens up the narrowing. So we do it, and we'll get back to it. Because we talk about all the complications of the other procedures. Fenestration has no death rate, really, but you can get esotropia, hemorrhage, vision loss. And shunts, actually, you can get infection, herniation, hematoma. There are a lot of complications from shunts. Anyone ever see a shunted patient? It's not fun. And then their pressure goes high, then it goes low, they're switching it. So venous stenosis has been described in IIH since 1995, and in 2002, Higgins did the first stenting. Well, because of time, I'm going to jump through here to the cartoon that shows you how CSF exits through the arachnoid granulations. But if you have stenosis, it's going to go more slowly. And then the high ICP that results will push the stenosis even more, causing even higher pressure, papilledema. And so it turns out, I'm just going to jump through here, there's 2 kinds of stenosis. Intrinsic, where it doesn't reverse when you lower the pressure, and extrinsic stenosis, where when you lower the pressure, it goes away. So it can be caused by the high pressure, but it too can cause high pressure. So it's like, I'm just going to jump ahead, a vicious circle, where you have venous sinus compression by the high pressure, called extrinsic stenosis, and that causes venous hypertension, bad CSF absorption, elevated CSF pressure, and more compression. And the circle goes on and on. It's like a vicious cycle. Okay, so it's like a chicken and an egg. Either way, if you stent the stenosis, the patient can do better. That's our theory. So we did a trial at Cornell starting in 2015 where we would put in the stents. And in the last 2 minutes, I'll just show you our results because we're pressed for time. I tried to fit in a lot here. This was our patient. We put in the stent. Opening pressure went from 33 to 18. Papilledema resolved. Visual fields resolved. So this was our best case. So I'm showing it to you. But now I'm going to zoom out and show you more cases. If we look at their CSF pressure, and you look, blue is pre-stent, pink is post-stent, you can see that the vast majority had an improvement in their opening pressure because we did lumbar punctures 3 months later on everybody. And they went from 36 average to 20.8 centimeters of water. You might say, well, that's great. Your stents help the pressure. What about their symptoms? Well, a lot of them had symptoms at the beginning, and it turned out that headache resolved in 20% and improved in a further 70%, so they did pretty well. Pulse-style tinnitus resolved in 76%, and we did a little study on that. Diplopia resolved in 70% and improved in 30%. Transient visual obscurations resolved in 74%. What about their actual vision? Here's their visual fields. In 48 eyes, the mean deviation improved in the vast majority, and the average mean deviation went from -10 to -4. In this case, there was no improvement, but that optic nerve already had atrophy. There was no way we could improve the vision. But in the eyes that had papilledema, they did well, and here's your Frisson grade. Mean from 2.3 Frisson grade to 0.5. And then finally, OCT went from a mean thickness of 209 to 96. Okay? And so we made sure that it wasn't due to weight gain. But some of them, 7 of 54 patients, had a relapse after we put the stent in, and they needed another stent for a new narrowed area. That can happen in about 13% of patients. And I won't go into that more. And we looked at the safety. We had 2 retroperitoneal hemorrhages, but otherwise, and 1 ruptured ovarian cyst due to the aspirin and clopidogrel that you have to start on these patients. Otherwise, the stent can what? What'll happen in the stent if you don't start them on aspirin? It'll clot up, yeah. And some of them had headaches that lasted for a week. And there are a lot of limitations to my study. This was not blinded, and there was no direct comparison with shunt where I could prove that it was better than shunting. But we tried to show that it was relatively safe and effective. And, there are a lot of other people, in addition to our group, who are studying venous stenting. And if you look at the larger group, and I've looked at 1,600 cases of stenting in the literature, there are 6 deaths from ruptured veins or other bad thrombosis. So it's not, just because it's not a surgery, doesn't mean it's perfectly safe. But I wanted to introduce it to you as one more tool that your neurologists and interventional neurosurgeons can do for patients of yours with IIH when they don't want to shunt. Anyone here ever see stenting in your institution? It probably is coming, in the coming 5 years. Do you have interventional radiologists? Talk to them, ask them, do you do stenting? And probably they'll say either they do, but they haven't talked to you about it, or they want to do it. And anyway, so it's one more tool for this. So to summarize, you guys, let's go back. All of these things can mimic IIH and cause high intracranial pressure. Look for them, think about them, especially venous disease, in your cases of IIH where it just doesn't add up.